Assalamu alaikum, good morning, good afternoon, and good evening, depending on your time zone. I know you guys are connecting from different country, from different time zone, so I make sure that I cover everybody. All right, today is the first day of the crash course. We're gonna start with the headache. Maybe I put it on slideshow. Yeah, this way. So the easiest one, the acute neurology, every case that we are doing, most of these cases that today we are going to do is part of the acute neurology topic. Okay, so we're going to start with the easiest one and very fun topic and most commonly tested topic in the licensing exam. Regardless of which exam are you preparing, MCQ1 or NACOSKI, headache will be in the exam. And especially if you're preparing for the MCQ1, you cannot miss this one. And I'm pretty sure that you guys know most of the topics about the headaches. Again, I'm going to point out the most important and commonly tested points of the headache. Okay, so by the end of this lecture, we should be able to identify the type or the different types of the headache, whether it is primary or secondary, and we should be able to identify the secondary headache, red flags before calling it a migraine or tension headache or cluster headache or primary headache. So investigation, what kind of investigation is supposed to be done for which kind of headache? Do we have to do it or not? Treatment, how we're gonna deal with a migraine, with a cluster headache, I mean in general, and with a primary headache, and with a different type of primary headache, and also with a secondary, whether the abortive treatment, for example, for migraine, what are going to be the preventive treatment, and which medication should be used at which specific time. For example, there are a list of the medication, but they're not supposed to be memorized. They're supposed to be picked based on the specific situation. Avoid traps. There will be some traps set for you guys in the scenarios and cases that you need to recognize it and avoid it. Okay, do not fall for those traps. Apply, solve realistic MCQ1 cases from the clue. I'm going to point out the clues, and based on those clues, you should be able to tell which one is which. All right. So the headache decision, danger before diagnosis. So it means when we have a patient with a headache, we don't care about the diagnosis. We care about their life first, right? So we make sure that we cover the we apply the ABC before we decide to go ahead and call it migraine, tension, or thunderclap, or this and that, or subdural or epidural hematoma or hemorrhage, right? So we don't care about the diagnosis at the beginning. We care about the patient life and safety. So once we take that out of the way, then we think about the diagnosis. For example, if you have a patient who has a headache and it looks like intracranial hemorrhage, I don't care what kind of or what is the diagnosis. First, I have to stabilize the patient. I have to make sure that the patient is not going to die. So whether it is subdural, whether it is epidural, whatever it is, I have to apply the ABC first, right? My ABC comes first before the diagnosis. So stabilize vitals, glucose, and conscious, and then screen, see if the red flags are positive. If the red flags are positive, for example, if it happened after trauma, if the patient is on some sort of blood thinner, if the patient has all other red flags that's supposed to be covered, then classify it. Based on those findings, classify it, whether it is primary or secondary. If it is primary, then you don't have to worry because most of the primary are clinical diagnosed, and I don't have to run any sort of intensive imaging or investigation, and then act upon that patient based on your finding and classification. If it is primary, you know what to do, start the treatment, And if it is secondary, then obviously you have to escalate. You have to do imaging, you have to do investigation. In most cases, you don't even have time for that. You just have to just run into the operating room. So exam rule, a familiar migraine does not cancel a new red flag. It means if a patient has history of migraine and he comes with a new finding, which raise an eyebrow, it doesn't mean it's still the migraine. So it means you need to rule out the secondary cause. So there is a way that we need to, sorry, I have problem with this, finding these. Okay. We have the spoon, the red flags, or I have a better one, which is paint spoon, this one. This one is actually different in Toronto Notes and any other resources that you can find in regards to the MCQ1 preparation. It is called Snoop. If I'm not mistaken, it is called Snoop. So I changed it to spoon and I made it even better, paint spoon. There is another mnemonic. So if you want to find the red flag, check for the paint spoon. So let's go check the paint spoon. It's much better than this one. Paint spoon. P stands for pregnancy. See if the patient is pregnant. Pregnancy is a red flag. If the patient is postpartum, it's another red flag. If the patient is on anticoagulation or blood thinner, red flag. If the patient is immunosuppression immunosuppression and the patient is on immunosuppressant, red flag. If this headache happened after a new trauma, especially head trauma, sorry. If the patient has tender painful red eye and it is unilateral, red flag. And also spoon systemic. The patient has systemic symptoms or finding on top of the headache. For example, the patient has headache, but on top of headache, the patient has fever. The patient has weight loss, or the patient has fever and neck stiffness, or the patient has headache, weight loss, or any other constitutional sign and symptom. Pattern change. If the pattern of the headache is progressive, changing with position, exertional, or Valsalva trigger. O stands for onset sudden. If it happens suddenly and the patient explains or tell you that this has been or this feels like it felt like a thunderclap and it feels like it is the worst headache of my life. Red flag. Older age, if your patient has headache and happens to happen in your patient who is older than age of 50. Neurological deficit, the patient has headache and the patient has deficit, neurological deficit, the patient develops seizure with it, the patient lost consciousness, or the patient has papilla edema, which shows the increased raised intracranial pressure. So think secondary headache when the red flags are present. So if you have these, it is most likely to be secondary headache rather than primary, rather than being a regular migraine, rather than being a regular tension headache, rather than being a cluster headache. The focus examination answer 4 questions. So if you're doing an examination, especially for those of you who are doing the NAC OSCE, so is the patient unstable? If the patient is unstable, I don't care about the diagnosis. I have to stabilize my patient first. Okay, this is the first thing, or the first question that I need to answer. If the blood pressure is abnormal, I have to fix it. If the temperature, if the oxygen, if the patient mental status is compromised. Is the brain involved? Check for the pupil, speech, visual field, power, sensation, or coordination. Or you can just see it in the physical examination. Is the pressure elevated? Fundoscopy for papillary edema. Look for the sixth cranial nerve palsy. Is there local clue? Red eye, temporal artery, neck stiffness, trauma, or TMJ, temporomandibular joint. When should a headache patient be imaged? Now, do I have to X-ray and do a CT scan or order image for all my patient? No. No routine imaging. For who? Typical recurrent migraine with a normal neurological examination. You know your patient. They gave you an clear-cut characteristic finding of migraine. And the patient comes always with this specific finding, which we are going to go through that, which is pound, right? With a pound. So if that is the case, you don't have to, because you know the patient has been suffering from migraine for a long time, and this exactly matches the characteristic finding of a migraine. The patient has a stable pattern. There's no sign of red flag. Why not? Low diagnostic yield and incidental finding. Best step diagnose clinically, educate, and treat. So for primary or those who doesn't have the red flag or pain stone, then I don't have to order any imaging. Now, urgent imaging for those who has secondary finding or who has secondary headache or who has the red flag present. Urgent imaging or investigation. And we do the non-contrast CT scan for anyone who has head trauma and headache with a head trauma. The patient mentioned the thunderclap. If you're suspecting hemorrhage or the patient has acute headache with a neurological deficit. So neurological deficit, for example, the patient has headache but cannot move the right side or left side, or the patient cannot, the patient has numbness, tingling sensation on the right side after that head trauma. CTA, when aneurysm or arterial dissection is suspected. CTV or MRV for suspected cerebral venous thrombosis. And MRI for mass, posterior fossa, pituitary, or atypical progressive cases, which we're going to cover all of them. Now, thunderclap headache. Thunderclap headache is very characteristic finding of subarachnoid hemorrhage. It could happen during sex activity. It could happen during accident. It could happen in somebody who is exerting. It could happen on someone with anticoagulation or after trauma. So instant peak intensity, worst headache of my life. The patient will say that. Exertion, neck pain, vomiting, or reduced level of consciousness. Image for this patient, urgent non-contrast CT scan of the head at CTA when aneurysm is suspected. If you're suspecting aneurysm, then CTA. So if CT scan is negative, further testing depend on the timing and clinical suspicion, often the LP or vascular imaging. So sometimes the patient may, with subarachnoid hemorrhage, remember this clinical picture they may give you might be almost the same thing like meningitis, except for the fever. For example, in meningitis, you have headache, you have nausea, and level of consciousness may decrease. The patient may have neck stiffness, and the patient will have fever, right? But in some cases, they may not have fever, especially in viral cases. But in subarachnoid hemorrhage, they will have all these symptoms, except for the fever. The only difference is when you do the LP, in some cases, the CT scan cannot detect the subarachnoid hemorrhage in early stage, so the LP may help you. So if a CT scan doesn't help, then you move on to LP. The difference between meningitis and subarachnoid hemorrhage, that in LP or CSF of somebody who has subarachnoid hemorrhage, you find blood. And this was the case in one of the subscription. So remember, they will give you a clinical picture of someone that who is exactly like meningitis, headache, level of consciousness a little bit decreased, the patient has neck stiffness, does not have fever, and also mildly have a fever, probably mildly have a fever because fever can happen due to a trauma, right? So mildly high fever, not very high, but the patient does not have any sort of, infectious suspicion, but the patient has a trauma. In that case, you do the CT scan, but CT scan is negative. It doesn't mean it is meningitis. So you need to do the LP, and the LP shows blood, right? So if it shows blood, it's not meningitis. Consider RCVS or CVT, dissection, pituitary apoplexy, and other thunderclap cause. So TRAP, CT negative does not automatically mean subarachnoid excluded. So if you're suspecting subarachnoid hemorrhage, CT is negative, it doesn't mean it's not subarachnoid hemorrhage. What is your next step? Do an LP. Okay, so the reason I put it here, it's a trap. Do not fall for this trap. They may give you a case of subarachnoid hemorrhage, then they give you in the same scenario that the CT scan is negative. So if CT scan is negative, you're like, okay, this is not subarachnoid hemorrhage, so this is definitely meningitis. I have to put the diagnosis of meningitis. Or what is your next best step? Meningitis. No, I have to do the LP. Okay. Primary headache have three very different signature: tension type, migraine, and cluster. So the tension type is bilateral, like the way you can see it here. It's like a band-like headache, pressure, activity, tolerated. It means the patient is still active, is working, and it could last maybe days. Migraine usually lasts 4 to 72 hours. Remember, if it continues beyond 72 hours, it is called a status migrainous. So 4 to 72 hours is migraine. If it lasts more than 72 hours, it is a status migrainous. So nausea, light sensitivity, activity worsen. So migraine is completely opposite of cluster headache. Migraine usually happens in female. I'm not saying it doesn't happen in male, but it is more common in female. Cluster is more common in male. Migraine usually happens during activity. Cluster headache loves to have activity because it helps with the pain. It means the pain happens when the patient is resting. For example, early morning, while the patient is watching TV, doing nothing, resting, it can happen. So it is the opposite. When you're very tired or when you're working too much, migraine. When you're resting, cluster. Again, when you're resting, migraine gets better. But when you're resting, cluster gets worse. So you need to start walking, exercising, getting more oxygen, you get better. So this is completely opposite. And also another thing about the migraine, that it has photophobia, phonophobia. I think we have more. Yeah, so the duration is different. 4 hours to 72 hours, which is 3 days. Beyond that, status. Migrainous, this one could be up to 2 to 3 hours. Now let's start going one by one. Migraine diagnosis, POUND plus associated symptom. What is POUND stands for? POUND is a mnemonic for the clinical finding of migraine. P stands for pulsatile. It means the headache is pulsatile, like heartbeat, like your pulse, right? 1 day duration, 4 hours to 72 hours can last. It is unilateral, but again, migraine could be bilateral, but mostly unilateral. But if they want to test you, remember they test you with the unilateral one. Nausea or vomiting, N stands for nausea, vomiting, U stands for unilateral, O stands for 1 day, P stands for pulsatile, and D for disabling, activity worsening. So it means it gets worse with activity and it is affecting the patient's daily life. Now the pattern, at least 5 attacks fitting the pattern, at least 2 pain features, unilateral, pulsatile, moderate, severe, worsened by routine activity, at least 2 of them. At least 1 associated feature, that pain, which is unilateral, which is pulsatile, should have associated symptoms or finding like nausea, vomiting, or both, or phonophobia or photophobia, or both. The duration, again, 4 to 72 hours when untreated or unsuccessfully treated. Always check, no better secondary explanation. Migraine evolves through 4 phases: prodrome, aura, headaches, and postdrome. Prodrome is hours to days, usually before the headache starts. Sorry, I'm talking about aura. So prodrome, hours, days, mood, appetite, fatigue, neck stiffness. Aura, usually 5 to 60 minutes, fully reversible, visual, sensory, or language symptoms. Before the headache starts, aura starts. And then when aura subsides, the headache starts. And it will last up to 72 hours. Then postdrome is fatigue, cognitive fog, and residual sensitivity. Almost like the same thing like a prodrome. So now for the aura, remember, they might give you a scenario with a migraine with aura, and also in the options they may give a scenario which is from migraine aura, but in the options there might be the diagnosis might be migraine with aura, TIA, ischemic stroke, or hemorrhagic stroke, or something else. So migraine with aura is very close to TIA, or transient ischemic attack. And the biggest difference or differential point is that migraine with aura starts gradually. But ischemia or stroke can happen suddenly. So this is the biggest differential points, okay? They might directly ask you what differentiate the migraines with aura from an ischemic stroke or TIA. The gradual progression of aura or migraine. But the ischemia is sudden. It starts suddenly, okay? Or they might give you a scenario that the patient has positive visual symptom. For example, the zigzag, the patient has visual issues or symptoms that's spreading. The patient even sometimes may have language issues like a stroke, which is not very common, but it might happen. The patient may feel needling, numbness, sensory deficit, even weakness on the right hand, but it actually progress or the onset is very gradually, as opposed to the ischemic stroke, which happens suddenly, okay? So this might be the reason I made it red. This might be a question. And this is also different color. So the positive visual, usually 0 to 5 minutes. After 5 minutes, the symptoms start, the visual and sensory symptoms starts, numbness, needling, this and that. And then fully reversible is between 20 to 60 minutes. The language, it may happen, but it's not very common. After it reversed, then the migraine happened. Migraine with aura is gradual. Again, please remember this. This is gradual as opposed to stroke, which is sudden. Positive spread and reversible. So TIA and stroke concern, it is sudden, negative loss of function. Another thing that differentiate the migraine from the stroke is, or TIA, is that migraine has positive symptom, stroke has negative symptom. For example, migraine has new symptoms that's adding on the patient. For example, the patient starts seeing things. For example, zigzag, right? It is add-on. It's a positive. That's why they call it positive. Positive, it means the symptoms adding on. But in stroke, you're losing sensation. You're losing the power. So you're losing, not adding, you're losing. So negative symptoms, stroke. Positive symptoms, usually migraine. Gradually progression or onset, migraine. Sudden onset, stroke. Migraine with aura, positive visual symptoms such as flashing, light, shimmering, zigzag, scintillation, scintillating spots, usually spreading gradually over minutes before the headache starts. Now, aura versus TIA, positive spread versus sudden loss. So my positive symptoms, flashing light. Like you don't see normally, regularly, you don't see the flashing light. But when you have the aura, you start seeing it. So it's adding on, right? Something that you didn't have. Now you have it. That's called positive symptoms. Zigzag, you don't see it regularly on a daily basis, but now the aura comes. When the aura comes, you have zigzag seeing, right? Or sights. Now, this is something that add on. Tingling sensation, you didn't have it, but now you have it. So it adds on. Gradually spread over minutes. Symptoms may occur in sequences, usually 5 to 60 minutes, and fully reversible. Headache often follows, but may be absent. Remember, the aura doesn't mean that 100% the migraine starts. We have people with the migraine with aura that the patient has the aura, but not the migraine. There are not a lot of them, but some people has migraine with aura that has the aura, but not the migraine. So the aura comes, migraine usually follows. But in some people, in some cases, the aura comes, the migraine doesn't appear. So if you see that, it doesn't mean it is not migraine. It is aura without migraine, okay? So TIA, negative symptoms, you're losing vision. You're losing sensation. See, you're not adding on, you have negative symptoms, you're losing. Language ability, you're losing. Sudden maximal onset with a gradual march, often simultaneous rather than sequential symptoms. New focal deficit, this is another important differential point, must be treated as a vascular until proven otherwise. Acute migraine, treat early and match severity. Okay, so based on the severity or stage of migraine, we have treatment for it. If it is mild to moderate, acetaminophen and non-steroid anti-inflammatory drug is the best choice. If they give you a scenario about someone who has migraine, but the migraine is mild and moderate, just go ahead and start them. Acetaminophen and or non-steroid anti-inflammatory. It's either or. You don't have to combine them unless you have to. But usually you start with solo medication. Take early and choose one effective option. One. Moderate severe triptan. If it is severe, it means acetaminophen didn't help. Acetaminophen, non-steroid didn't help. You combine them, didn't help. Then you move on to the triptan. Avoid significant vascular disease, assess pregnancy. It means that we don't use it if there is a vascular disease or if the patient is pregnant. So these are things that we need to pay attention. Nausea, vomiting, add antiemetic. Consider a non-oral route Why? Because the patient cannot take it. If the patient is vomiting, if I give him a pill, the patient will vomit it or puke it out, right? So what I can do, I can give him IV. ED, severe attack. If the patient is in emergency department and this is very severe, obviously I have to start with the IV fluid because the patient has lost the fluid, antiemetic to stop vomiting, and then start the non-steroid anti-inflammatory drugs. Avoid routine opioids because of addiction. Failure, try another triptan or route, combined triptan plus non-steroid. So I start with the acetaminophen. Doesn't help, I start non-steroid anti-inflammatory drug. If it doesn't help, I combine these two. If it doesn't help, I will go with the triptan. Okay. If the patient is in emergency room, I have to give him IV fluid, IV antiemetic, and non-steroid. So MCQ1 rule, opiates are not routine for migraine therapy. Medication overuse, I will talk about this. Sometimes people are taking too much medication, which backfires on them. So if you're taking a combination of painkiller for more than 10 days per month for 3 consecutive months, then itself, the medication itself causes headache, which is called a rebound headache. If you're using a solo medication for 15 days, solo 15, combined 10. Let's say you're using 3 medication. If you use these 3 medication for 10 days per month for 3 consecutive months, then the patient may develop rebound headache. If you're using 1 medication for more than 15 days per month for 3 months or more than 3 months, then the patient may develop rebound headache. When is a migraine prevention worth starting? So when do we start preventive treatment? Consider prevention when attacks are frequent. So they may give you a scenario, and then they may give you options of acetaminophen with non-steroid anti-inflammatory drug, triptan, and one of the preventive medication, for example, propranolol. Now, based on the scenario, how they create the scenario or lay out the scenario, you need to know which one is the best one. For example, if they give you a scenario that the patient has migraine and it's mild to moderate, you know which one to go with. If they give you in the scenario that the patient has already tried acetaminophen, non-steroid, didn't help, what is the next best step? Of course, you know that you need to escalate the treatment, go with the triptan. But if the patient has already used all these 3 and the patient is vomiting, you know that I have to move on with the IV. Or if they give you a scenario that the patient is having migraine frequently, let's say every other day. Not only that, disabling. When I say disabling, any health issue that interfere with your daily activity is disabling. If it interferes with your work, it is disabling. If it interferes with your studies, it is disabling. If it interferes with your social life, it is disabling. If it interferes with your sexual life, it is disabling. So any condition that affects your daily routine life, day-to-day living, it is disabling, and you need to do something about it. In case of migraine, we have to start preventive treatment, not for every migraine, but the migraine that makes you disabled, the migraine that affects your daily life, study, work, social, and sexual life. And it's more frequent. And if the medication is poorly, despite taking the medication, it is poorly controlled, or acute medication overuse. Now, in this case, I have to start the preventive treatment. But remember, we have, for the preventive treatment, we have propranolol, we have calcium channel blocker, we have anti-inflammatory Depressant, we don't have it here, but I'm going to show you. So we have antihypertensive medication as a preventive, anticonvulsive medication, we have antidepressant medication. These medication are not like you just memorize it. You pick these medication based on the condition. Okay, I think I do have a slide for it, but anyway, so choose by the comorbidity. Yeah, here we go. So we have propranolol, which is we can call it antihypertensive medication as well, but usually it is good for somebody who has anxiety, tremor, right? So for tremor and hypertension, you choose propranolol. The patient has migraine, which is very frequent, disabling, prolonged, more than 72 hours, and it is poorly controlled. I give him propranolol. So do I have to give it to everyone? No. If my patient on top of these condition has tremor and hypertension, this could be the best choice. If my patient on top of headache has problem with sleeping, the patient has insomnia, the patient has depression, I would go with amitriptyline. The patient, not only that, the patient has, for example, some sort of pain. It's good for pain or neuralgia. It's good for neuralgia. So I would go with that amitriptyline because propranolol doesn't help with neuralgia, but amitriptyline will help with that. Topiramate is another condition. If my patient also has this condition on top of that, he's candidate for seizure. Why not? I go with this. But I have to know that in which condition, which I'm going to go deep into it, in which condition I cannot use these medication. For example, if my patient has kidney stone, urethral stone, if the patient is taking too much vitamin D, vitamin C, in these conditions, or the patient has renal failure, I cannot use the topiramate. And also if the patient is pregnant. Newer option, monoclonal antibodies and GPANs are evidence-based option in Canada. So CGRP, calcitonin gene related peptide, is a newer option for the migraine. And chronic migraine, again, for the chronic migraine, they may give you a scenario for a patient who has this condition for a long period of time, or they mentioned the patient has chronic migraine. What is the best option for the chronic migraine? For that, we use the botulinum A is an option. Diagnose 15 or more than 15 headaches per day, per month. Measure benefits, use a diary, meaningful response is commonly more than 50% reduction. Sorry, I have to move this. Measure benefit, use a diary, meaningful response is commonly around 50 or more than 50% reduction. So migraine prevention, choose the drug that fits the patient. Again, prevention is a match, not a memorized ranking. So these are the medications that you can use for a preventive treatment as a preventive options or preventive treatment or prophylaxis treatment of migraine. But they has to be chosen based on the patient's condition. It has to match. It has to be a best match for the patient. We don't have to memorize it. Yeah, propranolol is, for example, a preventive medication for all migraines. No, it cannot be like that. Of course, it is one of the safest one, but based on patient, you have the best choice. Okay. For example, your patient has hypertension and tremor plus migraine. When I say migraine, I mean the migraine that needs preventive treatment. Frequent, disabling, prolonged, cannot be controlled. So for that, we use propranolol or metoprolol. Hypertension is also controlled, tremor is also controlled, and migraine can be also controlled. But The major trap is if they mention asthma and bradycardia, then it is going to be a bad choice. Migraine, disabling, patient with asthma. So in that case, I cannot use this. Okay? If the patient has bradycardia, I cannot use this. Why? Because it causes bradycardia. It causes asthma, even though it's selective, but again, it will cause somehow asthma. It's not a good choice. Amitriptyline. If you have a patient who has migraine, frequent, disabling, long period of time, and the patient has insomnia, the patient has depression, the patient has peripheral neuropathy, the patient has fibromyalgia, the patient has neuralgia. For that patient, the best medication is amitriptyline. With one stone, I can hit a lot of birds. I can control or prevent the migraine. I can control depression. I can control the peripheral neuropathy. I can control the fibromyalgia. I can control the neuralgia. So for this specific patient, I can use this medication. Topiramate if it is a weight neutral preference. And if the patient is epileptic and the patient has migraine, this could be the best choice. But again, for amitriptyline, remember, sedation is if the patient has already sedated, if the patient is already has a problem with the sleeping, he is dealing with a hypersomnia, he's sleeping all over the place, anywhere at any time. So this is not going to be a good choice. If the patient has any if the patient is allergic to this medication, or the patient has already developed anticholinergic side effect of medications, or if the patient is elderly, the patient has heart issue, arrhythmia issue, then in that case, amitriptyline is not going to be a good choice. So topiramate, cognitive effect, stone, as I mentioned before, stone, pregnancy, and also anyone who is, sorry, I think it's a slideshow, so I can't add it, just write it down. Anyone who is taking a lot of vitamin D, vitamin C cannot use topiramate. So they may give you a scenario about someone who has migraine. On top of that, the patient is on high dose of vitamin D and vitamin C, and then you cannot use topiramate. Calcium channel blocker, if somebody has hypertension and migraine that requires preventive treatment. So calcium channel blocker would be a best choice, but if the patient is pregnant, then no. The CGRP, which is currently very commonly used in Canada, calcium gene-related peptide, frequent migraine or failure, the treatment is not responding, or the patient is intolerant, then in that case, we can use this medication and agent-specific caution coverage. So they don't have a lot of information on what are the side effects or the condition that they shouldn't be using it. But anyway, for the chronic migraine, onabotulinum toxin A, not for a specific episodic migraine. It is for the chronic one. So I think this is the best slide. You should have it in your account. So the best fit for the mild to moderate attack, we can use acetaminophen or NanoStreet. For example, there is an example. A 24-year-old with an infrequent migraine, no vomiting or no red flag, start acetaminophen. Why? Because it's mild. Now, if it is moderate to severe migraine or failure to simple analgesic like acetaminophen and NanoStreet, so in that case, we start the triptan or sumatriptan. 35-year-old with a severe pulsatile migraine and nausea, ibuprofen failed, no vascular disease. So ibuprofen, and also I should have added the acetaminophen combination of both. So if that failed, then the next step would be sumatriptan. Why? Because it's moderate to severe, and the first step failed. So we move on to the second step. Now the third one. Best fit acute migraine when triptan fails is poorly tolerated or vasoconstriction is undesirable. So 62-year-old with a migraine and prior myocardial infarction, consider a triptan, a G-PANT in a state of the triptan. Antiemetic, if the patient has vomiting, antiemetic. You have to admit the patient. Always, any patient who has vomiting shouldn't be treated as an outpatient. So it means you treat the patient, at least you have to temporarily admit the patient, start the IV treatment. Once the patient is able to tolerate orally the medication, then you can dismiss the patient and treat it as an outpatient. Now, the last but not least, hydroergotamine, best fit, selected prolonged or refractory migraine under chlinician or special supervision. So for this one, again, it has to be done under supervision, and if it is refractory, not responding to any other medication. So 40-year-old with a prolonged refractory attack despite the standard acute therapy, supervised DHE may be considered. Migraine, again, I think we did this, but we have a case, a 42-year-old with a frequent migraine, hypertension, and hand tremor, no asthma or bradycardia. So what is the best choice preventive medication? Beta blocker, right? Propranolol. Measure, avoid non-selective beta blocker is significant in asthma. Use caution with the bradycardia. Now for this one, example, a 35-year-old has migraine, poor sleep, frequent tension type. One more thing that I forgot is if there's a combination of the tension and migraine, amitriptyline will be the best choice for preventive, okay? Now, topiramate, a 29-year-old has 8 migraines per day per month, 8 migraines per day per month, normal cognition, no kidney stone, and no pregnancy potentials. So cognitive slowing, paresthesia, kidney stone, and teratogenic are the major trap. Candacertan or the calcium channel blocker, again, same thing, hypertension. You need to use that. The CGRP targeted best fit. A 38-year-old has disabling frequent migraine despite 2 appropriate prevention trial. So you use this one. And this for the chronic, a 45-year-old has more than 15 headaches a day per month, including 8 or more than 8 migraine per day for more than 3 days. So this is for the chronic prevention. Now, migraine during pregnancy, safety changed the answer. Acute treatment, first choice is acetaminophen. Let's say you have a patient, the patient is pregnant, and the patient has migraine. What is the first, best, and safest choice? Always go with acetaminophen. Non-steroid, the trimester dependent, avoid in late pregnancy, especially in second and third, we try to avoid it. Antiemetic, choose based on obstetric safety. Antiemetic, choose based on obstetric safety. Triptan may be considered with the clinician guidance. Sumatriptan has the most data. So usually we don't use it, but unless the benefit outweighs the side effect. Prevention and vascular clue. Avoid valproate because of the major fatal risk. So we don't use it. It's not safe. Even if it is epilepsy, we have to consider changing it to lamotrigine. Avoid topiramate when pregnant. Discuss contraception and pregnancy plan. New aura or focal sign. Do not assume migraine. Consider a stroke if there is new focal sign. For example, the patient is losing vision. The patient is losing, for example, sensation, or completely the power of the right or left side. Headache plus hypertension after 20 weeks. Evaluate urgently for, this should be 20 weeks of gestation. Preeclampsia. We will discuss every single one of them. Tension type headache. So what is the typical clue? This is going to be mentioned. bilateral band-like pressure. Okay, these are the key words for the tension. It will be band-like and it will be bilateral. Mild to moderate, not very important, not worsened by routine activity, no vomiting. This is differentiating it from migraine, or at most one phonophobia or photophobia, at most one. So it means if you have it, it doesn't mean it is 100% migraine. It can happen in tension as well. So management, acetaminophen or non-steroid, frequent chronic, consider amitriptyline. If it is frequent. So amitriptyline, if you guys remember, we said that if we have a combination of migraine and tension, we use this. We use the amitriptyline. So one of the best time to use the amitriptyline if you have a combination of tension and migraine, or if there is a frequent tension that's not responding to other medication like acetaminophen or non-steroid. Non-drug sleep exercise, stress management, physical therapy when indicated. Avoid excluding the frequent analgesic use because it will cause rebound headache. So cluster headache, again, as opposed to migraine, usually male, as opposed to migraine, usually during rest, early morning, after sleep, after like usually at the time that you wake up. And it has another characteristic finding that the patient will have tearing and rhinorrhea from the same side. It could be unilateral. Usually it is like a coin-like pain. It could be in the temporal area. It could be in the eye. It could be at the forehead or frontal area. It could be at the top of the head. It could be anywhere like a coin. But that side, if it is on the right side, the patient will start tearing from the same side and the patient will have rhinorrhea from the same side. Okay? So excruciating unilateral orbital temporal pain, which is very common, this side, very common, here and here, like coin-like, okay? Here and here. But it could happen here, it could happen here, it could happen anywhere. But most likely, if they give you scenario, it will be very specific to help you out to understand this is cluster headache. It could be like orbital or temporal. 15 minutes up to 8 attacks per day, same side tearing, very important, same side tearing, red eye, rhinorrhea, or ptosis of the same side. It's not going to be contralateral, ipsilateral, same side. Occurs in bouts over weeks, restless and pacing or agitated. So as opposed to migraine, when the migraine happens, the patient goes in a room, he's trying to make it as dark as possible, as quiet as possible, and then in the silence of that room, she sleeps it off and wake up, everything is fine. As opposed to that, cluster headache has to get up, run, walk, exercise, do anything that requires you to breathe faster to get more oxygen, and it will help you to get better because the treatment is 100% oxygen. Preventive verapamil. So remember, verapamil is the preventive treatment of the cluster headache. Candacertan is also calcium channel blocker, is the preventive treatment of migraine. Okay, so ECG monitoring, bridge short steroid course may be used while prevention begins, but usually I haven't seen anyone with cluster headache to go on steroid. Trap oral analgesic are too slow. Do not confuse restless with migraine. Medication overuse, remember, over 10 days per month, triptan, opioid, ergotamine combination. So if it is a combination, like 3 medication, 2 medication for more than 10 days per month, it is, and regular use for over 3 months, it is medication overuse or rebound headache. If it is one medication, either acetaminophen or non-steroid for more than 15 days per month. Management explain the cycle, withdrawal restrict overuse medication, optimize prevention, provide follow-up. Giant cell arthritis. So giant cell arthritis is not a primary headache. So we are going to the secondary and more complicated headaches now. So for the giant cell arthritis, remember the clue is very, very important. Very important. Usually if they give you a scenario, the age will be over 50. The age will be over 50. Age over 50 with new headache. It could be male or female. Again, remember, mostly they will give you a female. I forgot to mention it here, but please write it down. Mostly female, mostly more than 50, mostly the ESR and CRP is high, especially ESR will be more than 50. Age more than 50, ESR. If it is not more than 50, don't think that it's not giant cell arthritis, but in most cases, it's more than 50, okay? Female. So I think I did have a mnemonic for it. F, female, more than 50, age, more than 50 ESR. And also frail, yeah, which is also, again, elderly. So age is more than 50, ESR CRP is high, and the barricade put it more than 50, but it could be less than that, okay? Don't judge me based on that. If it is less than that, it could be less than that, but in most cases, it will be very high, more than 50, and it will be female. Jaw claudication or scalp tenderness is very important clue, but out of all these, remember, jaw claudication is very prominent and very important finding of the giant cell arthritis, jaw claudication. If you have a question that which one of the following finding is the most commonly or most common finding in giant cell arthritis, it will be the jaw claudication, okay? Visual symptoms are diplopia, PMR symptoms, and elevated inflammatory markers. So here, inflammatory marker, ESR and CRP. And next best step. So if you have giant cell arthritis, you have an elderly woman, she is here and she has headache on the temporal area, and you can check and it has a tenderness, right? You can see the artery even tender. And the patient has also jaw claudication, visual problem. What would be your best next step? Diagnose, or you have to start with a steroid, high dose of steroid immediately when suspicions is very high. You started to save the vision, because once the blindness happens, it is irreversible. That's why we start with a high dose of steroid to save vision. Do not wait for the biopsy. Biopsy, if they are asking you what is the confirmatory test for the giant cell arthritis, is the biopsy of the artery. But we don't have to waste. Do we have to do it for the confirmation? We should, but we shouldn't. This should not delay the treatment. Or ultrasound before treating, okay? Urgent specialist assessment, especially with the visual symptoms. Confirm diagnosis with a temporal artery imaging and biopsy pathway. So it means you can do it, but do not delay the treatment. Start the steroid as soon as possible. So this is going to be a complete explanation of giant cell arthritis. What is the giant cell arthritis? Large vessel granulomatous vasculitis affecting medium and large arteries, especially branch of the carotid artery, usually the ages more than 50. Examine lab tender or reduced temporal artery pass, ESR and CRP is elevated. Again, ESR could be more than 50, but if it is less than 50, it's still the giant cell arthritis if the other characteristic clues are matching the giant cell arthritis. Normocytic anemia may be present. Major complication, irreversible vision loss. Irreversible, it means if the blindness happened, that's it. You cannot reverse it. And that's why, and that's the main reason that we need to start the steroid right away. If you have a giant cell arthritis and they're asking you what is the best next step, high dose steroid. If they're asking you what is the confirmatory test, biopsy. Okay. But if they ask you what is the best next step, do you have to do the biopsy or the treatment? The treatment first. Forget about the biopsy because it takes longer time. By the time you get the result, the patient is blind. And that we don't want. A stroke is less common, but possible. Classic clue, new temporal. I think we did talk about this. Constitution sign and symptom. The patient will be fatigue, fever, weight loss. Usually, with the temporal arthritis, the patient will lose weight. They may be overweight or normal weight, but during the disease, the patient will start losing weight. Diagnose, clinical suspicious is critical. Temporal artery biopsy confirms the diagnosis. Do not delay the treatment while waiting for the biopsy. Treatment high dose steroid immediately if suspected. Add aspirin in selected patient when appropriate. Tocilizumab may be used in some cases, urgent ophthalmology, rheumatology, involvement of the visual symptoms. So, case 72 years, the age is 72, above 50, woman, female, right? Presents with a new unilateral temporal headache, scalp tenderness, jaw pain while chewing, and brief episode of blurry vision. ESR is markedly elevated, suspected giant cell arthritis, and start high dose steroid. Raised intracranial pressure, position, and papilla edema matters. So suggestive First of all, if they want to test you on the raised intracranial pressure, again, they will give you a scenario about someone. It could happen to anyone. Again, it could happen to anyone, but in terms of gender, they may give you a female gender. Not only that, the patient will be obese. As opposed to giant cell arthritis, you're losing weight. The intracranial pressure or idiopathic intracranial pressure raised or increased, the patient will be female. But again, if it is male, do not blame me for it. But usually they will give you a scenario about the idiopathic intracranial pressure, a female patient, obese patient. And the patient not only have headache, papilla edema is positive, right? So intracranial pressure causes papilla edema. So you will have middle-aged female, obese, and headache. The headache have a characteristic picture. It's worse lying down. It is worse in the morning. It gets worse with Valsalva. Maybe they mention it directly, maybe they imply it. How? For example, the patient has headache, but it gets worse when the patient is tying her shoelace. So when the patient is bending forward, the headache gets worse. It means the intracranial pressure is increasing. So maybe they are not saying it directly, but they may explain it indirectly in the scenario, okay? Or the patient is having headache, but it is okay or tolerable while the patient is standing or walking. But when she sits down or when she is trying to tie her shoelace, it gets worse. It is worse in the morning. It is worse when the patient starts to pick up something from the floor, or when the patient has somehow, for example, sit down and the patient wants to stand up. So at this time, the headache gets worse. These are the key findings of intracranial pressure raised. Transient visual obscuration, pulsatile tinnitus. Pulsatile tinnitus means the patient has tinnitus, but it's pulsatile. It gets lower and then higher, lower, higher, lower, higher. It's like with every heartbeat, it gets higher. Papilledema, possible sex cranial nerve, nausea, vomiting, or reduced consciousness. So these are positive. Why? Because the intracranial pressure is high. Safe sequences, angio neuro imaging, venous imaging if the CVT, cerebral venous thrombosis possible, lumbar puncture only after mass lesion is excluded. So it means you need to do the CT scan and then the mass and lesion is excluded, then you can do the LP. Measure opening pressure and analyze its CSF when appropriate. We don't do it for everyone. So what is it? The intracranial pressure, a disorder of the elevated intracranial pressure with a normal brain structure, classically occurs in a young woman, okay? Middle-aged young woman, but can occur in others. Important because untreated papilledema can threaten vision. The clue: daily diffuse headache, transient visual obscuration, pulsatile tinnitus, diplopia from cranial nerve 6, papilledema on fundus exam or fundoscopy. Worse with the coughing, Valsalva maneuver in some patient, and also with, again, I have seen the cases while the patient is tying her shoelace. Risk factor: female, sex, obesity, recent weight gain, and also another thing, we need to remember that there are certain medications that increases the intracranial pressure, which is tetracycline, doxycycline, which I forgot to put it. You can write it down. Vitamin A or retinol, growth hormone, less commonly associated endocrine disorder, PCOS, hypothyroidism, and Cushing syndrome. So remember these risk factors, they will be positive in the scenario. Diagnose: brain imaging first, MRI, MRV, to exclude mass lesion or venous sinus thrombosis. Once they are ruled out, then you can do the lumbar puncture, elevated opening pressure with the normal CSF composition. Opening pressure will be more than 25, or they may even do it and mention it in the scenario. For example, you have 35-year-old female. She is, let's say, 100 kg, or BMI is, let's say, 30, and the patient has headache after doing the CTV or MRV. They did the lumbar puncture and the opening pressure is 28. So over 25 is high. This is exactly giving you the clue about the high pressure of the intracranial. Papilledema supports the diagnosis. Neurological examination is often otherwise normal, except the possible cranial nerve 6 palsy. So how do we treat? So one of the main risk factor is obesity, right? So we can't change the gender, which they usually do it normally now, but we don't do it for the headache, right? So what is possible to be changed, we can do it. For example, the weight, change the weight. Weight loss is the key. 5 to 10% can significantly improve the symptoms. Acetazolamide is the first line to reduce the CSF production. So if they're asking you, let's say I gave you a scenario, a 35-year-old female, 100 pounds, has a headache, and it gets worse when the patient is tying her shoelace. If I ask you what is the first best next step, imaging, right? So you would say MRI or MRV. So the MRI, MRV, and CT scan has been done, and there is no lesion, no mass. What do you do next? You would say LP. If I say the LP is done, the opening pressure is more than 25, so you know that it is high. So I'm asking you, what is the best next non-pharmacological treatment? See, what is the best Next, non-pharmacological treatment. I'm specifically asking you about treatment which has nothing to do with prescription of medication. No medication. Your answer would be lose weight, 5 to 10%. Significantly improve the symptoms. If I say what is the best next pharmacological step or pharmacological therapy, then you would say acetazolamide. Topiramate may help in selected patient, also aids with weight loss. Like if the patient wants to lose weight, this helps with both the headache and also it helps with the losing weight. But is it the best choice? No, acetazolamide is the best choice. That is the second choice. Serial ophthalmology follow-up, visual field monitoring, urgent surgical option for the treatment vision, optic nerve sheath, fenestration, or CSF shunting. Focal deficit or altered mental status suggests another diagnosis because the patient will not have, with idiopathic intracranial pressure, the patient will not have neurological deficit. Fever, meningitis suggests infection. Consider cerebral venous sinus thrombosis. If atypical finding, do not diagnose IIH or idiopathic intracranial hypertension before excluding secondary cause. So you have to rule out the dangerous or secondary reason for the headache, then you can call it the idiopathic intracranial hypertension. Example case, a 28-year-old woman with the obesity presents, female, middle age or young, obesity, daily headache, brief episode of blurry vision, and whooshing pulsatile tinnitus. Fundus exam shows bilateral papilla edema. MRI is normal. MRV exclude the venous sinus thrombosis, and lumbar puncture shows an elevated open pressure, which is more than 25, with a normal CSF. Diagnose idiopathic cranial intracranial hypertension and begin weight loss. What is the first best non-pharmacological treatment? Weight loss, counseling, plus if this doesn't help, then acetazolamide. Headache, papilla edema, cranial nerve palsy, and I think we're done with this. The painful red eye is not a migraine until examined. So, acute angle closure glaucoma, severe eye or head pain, it will be red. The key finding for the acute angle closure glaucoma, halos. So it will be severe. It will be severe eye pain or headache. It could be left, it could be right, but it is unilateral. And it will be red, and the vision will be hollow, fixed, mid, dilated pupil, and nausea. Urgent ophthalmology, pressure lowering treatment. You have to start decreasing the intracranial, intraorbital pressure. Meningitis, fever, headache, neck stiffness, altered mental status. Sometimes you may have rash for the Neisseria. Immediate empiric treatment after culture. Do not delay the for the lumbar puncture when unsafe. So we start the antibiotic. We take the culture. We do not wait for the result. We start the antibiotic. Sinusitis, prurulent nasal symptoms, facial pain, uncomplicated cases, or clinical. Avoid labeling isolated headache as a sinusitis. TMG, cervical sources, pain with the jaw movement or neck, mechanical, normal neurological examination, conservative treatment after excluding the red flag. Preeclampsia, hypertension, visual symptoms, seizure, or altered mental status. Anytime after 20 weeks of gestation. Cerebral venous thrombosis, progressive headache, seizure, focal deficit, or a CTV or MRV. Post-dural puncture headache, worse headache upright, better lying flat, as opposed to intracranial pressure, which you stand up, the headache is better, but when you lie down, the headache gets worse. The postural, when you stand up or sit up, the headache is worsening, but when you lie down, it gets better. It is the opposite of intracranial. The postural puncture headache, posterior puncture headache, is the opposite of intracranial hemorrhage. Reversible cerebral vasoconstriction, recurring thunderclap, headache, vascular imaging, pituitary apoplexy, sudden headache, visual loss, ophthalmologia, endocrine instability. Trap, postpartum seizure plus seizure or focal deficit is not just a migraine. We need to rule out this. Okay, one by one, meningitis. I think meningitis, everybody knows the patient will have. So it is inflammation of meninges, can be bacterial, viral, fungal, or tuberculosis, acute meningitis. We will cover it in infectious, but just quickly covering it. So the patient will have fever, headache, stiffness, photophobia, nausea, vomiting, altered mental status, an infant, poor feeding, lethargy, bulging fontanelle, enterofontanelle. So neonate, the group B Streptococcus, E. coli, Listeria monocytogenes, children a little bit younger, Neisseria meningitis, Streptococcus pneumonia, adult, Streptococcus pneumonia, Listeria, and gram-negative. Viral, the most common one is enterovirus. So 21-year-old student present with fever, severe headache, photophobia, neck stiffness, vomiting, and petechial rash. He appears confused, suspect acute bacterial meningitis, obtain blood culture, and start immediate empiric IV antibiotic plus dexamethasone. Dexamethasone is for inflammation. So acute angle closure glaucoma is ophthalmologic emergency caused by sudden closure of anterior chamber angle. So remember the anterior chamber angle. You need to remember this. Aguinous humor cannot drain, causing rapid rise in the intraocular pressure. Aguinous humor, remember this one, can repeat rapidly threaten vision if not treated immediately. Sudden severe unilateral eye pain, red, blurry vision, halo around lights is very clinical characteristic finding. Frontal headache, nausea, vomiting often occurs in dim light or after pupillary dilation. Usually risk factor, older age, hyperopia. So again, for the acute ankle closure glaucoma, it will be female, older age, hyperopia, farsightedness, Asian ancestors, medication that dilates the pupil and have anticholinergic, some symptomatic effects. Where is the, yeah, here, example. 76-year-old woman develops sudden severe right eye pain, blurred vision, headache, and vomiting while watching a movie in a dark theater. So it usually occurs often in dim light. Okay, see, it happens while watching a movie in a dark theater. Her eye is red, the cornea looks hazy, the pupil is mid-dilated and poorly reactive, and intracranial pressure is markedly elevated. Remember, if they have this scenario, they ask you, what is the next step? You have to refer the patient to emergency room if there is any option. The specialist has to be involved. If they're asking you another question, what is, after doing all this, what is the next step in treatment? Decrease the pressure. How do you decrease it? With beta blocker. And the best one is the timolol drops locally, right? And then if the pressure starts to go down on its way down, then you can use only after the IP begins to fall. So pilocarpine. The reason I'm asking, because these questions were in most of the subscription. So the best treatment is timolol to start with, decreasing the pressure. Once the pressure starts to go down, if they ask you what is the next step, then you can start pilocarpine only after the pressure starts to go down. You can use it before or after that, before that. Acetazolamide is another medication that is also used for the acute acute angle closure glaucoma. And if they ask you what is the definitive treatment, is laser therapy. Okay, the first timolol. After the pressure starts to drop in, pilocarpine. Definitive treatment, laser. If they ask you what is the investigation, fundoscopy, also you can tonometry to check for the blood pressure. The intraocular pressure. Tonometry. If they're asking you what is the best next step in investigation, tonometry. If they're asking you about the confirmatory test, go with the gonioscopy. Tonometry is the first best investigation. Gonioscopy is the confirmatory investigation. Sinusitis, I think it's easy, so we're gonna skip this one. TMJ, cervical source headache. I doubt it if you get any question from this, but temporomandibular joint dysfunction and cervicogenic headache are common secondary cause of the headache, and facial arises from temporomandibular joint and masticatory muscle. Cervicogenic headache originates from the cervical spine structure, especially upper cervical joints, and muscle pain may reduce to the temple, ear, and occipital forehead. So I'm just going to go to the example case. A 43-year-old patient has recurrent unilateral temple pain with the jaw aching and clicking that worsen while chewing. Another patient has occipital headache, pain with a stiffness that is triggered by the prolonged computer work and neck rotation. Consider TMJ source in the first case and cervical source in the second. So TMJ in the first one and cervical source in the second one. Not very commonly tested. Preeclampsia, very commonly tested, very commonly tested, and you have to know this. So what is it? New onset hypertension, which happens after 20 weeks of gestation, usually defined as a blood pressure of over 140 to over 90 on 2 occasions, at least 4 hours apart. If someone who is pregnant after 20 weeks of gestation develops hypertension, which is above 140 over 90, and you check it twice, 4 hours apart, and still it is high, it is preeclampsia, plus either proteinuria or evidence of maternal end organ dysfunction. It can occur with or without edema. Hypertension after 20 weeks, proteinuria is more than 300 milligram per 24 hours, or protein creatinine ratio is 0.3, or dipistic if better test is, no better test is available. So dipistic is not commonly used. Remember, if you see it, we don't use it unless all the other best tests are not available. Severe range, if it is above 160, this is severe. 160 over 110 is severe systolic, or diastolic is 110. May present with a headache, visual symptoms, right upper quadrant pain, epigastric, or reduced fetal growth. Severe, not only the blood pressure is going to be 160 or above, thrombocytopenia, elevated creatinine, the pain, pulmonary edema, new onset severe headache, or visual disturbance. Common symptoms and sign: headache, blurry vision, flashing of light, facial or hand swelling, high blood pressure, hyperreflexia may be present, decreased fetal monitoring, and fetal growth restriction can occur. Maternal fetal risk. So maternal, what are the risks? Eclampsia, HELLP, stroke, placenta abruptia, and pulmonary edema. For the fetal, growth restriction, prematurity, fetal distress, stillbirth, and severe untreated case. Management: confirm blood pressure and assess maternal. So we do all this because these are important to know this the CBC, the platelet. Why? Because the platelet will be low, and also creatinine will be high, AST/ALT will go high, urine protein will go high, fetal assessment growth, non-stress test, and CTG as appropriate, control severe blood pressure, magnesium sulfate for seizure prophylaxis in severe preeclampsia. Definitive treatment is delivery. If they're asking you about the definitive treatment, is delivery. Depends on gestation age and severity. If mild and preterm, close maternal fetal monitoring. Okay, these ones, okay. Normal pregnancy, the blood pressure should be here like this much, but in preeclampsia, this much. Proteinuria none, so compare it with this side. Now let's do an example. A 30-year-old woman, 33 weeks of gestation, above 20 weeks of gestation. So swelling of the hands and face and blood pressure of 166 over 108. Urine protein is positive and liver enzyme is elevated. Diagnose preeclampsia with a severe feature, stabilize the mother, start magnesium sulfate, control severe blood pressure, and urgently involve obstetric delivery planning. 33. So emergency red flags, severe persistent headache, visual loss, right upper quadrant, shortness of breath, seizure, markedly elevated blood pressure. Cerebral venous thrombosis. Again, this is also not commonly tested, but something that we have to keep in mind. A thrombose in the dural venous sinus or some cerebral vein impair venous drainage, leading to increased intracranial venous infarction, pressure, venous infarction, and hemorrhage. Pathology, thrombose in the venous sinus or cerebral vein, venous outflow obstruction, and then the venous pressure is increased. So they're not going to ask you all this. All right. MRI, the most important thing that if you are suspecting this, you need to do the MRI, MRV. These are the golden standard. They might ask you what is the golden standard for this patient. It should be the MRI with MRV. Finding lumbar puncture, if no mass, increase opening pressure, normal, not opening pressure, normal or mildly abnormal CSF. So the clinical feature for this patient would be headache, most common symptom, subacute on progression, nausea, vomiting, obviously seizure. Something to remember that headache with nausea, vomiting, seizure should raise concern about the cerebral venous thrombosis. Seizure with focal or general seizure with headache, nausea, vomiting should raise concern about the cerebral venous thrombosis. And also, not only that, if the patient has headache after postpartum, the chances of cerebral venous thrombosis is very high. After surgery, again, chances of cerebral venous thrombosis, surgery, obesity, pregnancy, and also if the patient has seizure. Focal neurological deficit, hemiparesis, aphasia, visual field defect, papilla edema, intracranial pressure, altered consciousness. Can mimic migraine, meningitis, stroke, and tumor. Okay? Where is the example? I don't have example for this. Okay, treatment, anticoagulation. Cornerstone of treatment of the venous thrombosis, syncytial thrombosis, the cornerstone is the anticoagulation. Low molecular heparin, then move on to the warfarin. For 3 to 12 months, even if the hemorrhagic infarction is present. So for the cerebral venous thrombosis, you start with the low molecular weight heparin, change it to warfarin for 3 to 12 months. Manage underlying causes, whether it is infection, OCP, if it is OCP, stop it. If it is systemic disease, treat it. Intracranial pressure management, head elevation, acetazolamide, mannitol, avoid hydration, like every other intracranial pressure that we manage. Seizure management, anti-epileptic medication. Key points. Think of cerebral venous thrombosis in a young patient with a new headache, seizure. Remember, young patient, headache, seizure. If you see headache with seizure, always think about cerebral venous thrombosis. It is cerebral venous thrombosis until proven otherwise. Okay? Or focal deficit, especially with risk factor. MRI with the MRV is the diagnostic test for choice. Anticoagulation improves the outcome. MCQ traps that repeatedly cause MARDS. This is very important. Pay attention, okay? Don't fall these traps. Normal CT scan, no ischemia or ischemic, subarachnoid hemorrhage. So if it is normal CT scan, it doesn't mean it's not ischemia. It doesn't mean it's not subarachnoid hemorrhage. Interpret CT scan in the clinical and timing context. So it means you still have to do further investigation and or based on the clinical finding. Migraine history is not migraine today. A new red flag changes the workup. If you have somebody who comes with a migraine always, and now you see a new finding, it is not migraine. You need to do further investigation. For example, let's say you have a patient who has been your patient for, let's say, 10 years, and always, the patient is coming with phonophobia, photophobia, headache, unilateral headache, and also nausea, vomiting. Now the patient has sudden right side weakness. So it is not migraine. Because of this new finding, I have to do further investigation. It might be TIA. Aura is not automatic reassurance. New motor persistent or sudden negative symptoms need urgent assessment. Same thing. Cluster, patient lying still. Cluster causes restlessness. Migraine prefers stillness. So these are the key points to differentiate. More rescue medication, better care. Frequent use can cause medication overuse headaches. So it's not always answer to the problem. In most cases, it may cause the problem. Like if you take it for, let's say, if it is combo of 3 medication or painkiller for more than 10 days, for more than 3 months, it causes rebound headache. If it is a solo medication for more than 15 days, it causes. So more medication is not always the solution for the problem. It may be the main reason for the problem, or might be another reason for the problem. Biopsy pending, delay the giant cell arthritis treatment. No, we never delay, or they may give you a scenario about giant cell arthritis and they say, what is the best next step? The option A will be biopsy of the artery, which is obviously the confirmatory test, right? And you have to confirm it. And then they put this, that, X, Y, Z, and at the last option, they would put high dose of steroid. Since you are, when you're doing the exam, you're not only doing the exam, you're racing against time, right? So you are very stressed. So as soon as you see the biopsy, you just circle it. And this is the right answer. I know giant cell arthritis biopsy, but just go up to the end, like up to the option E, see what is the other option, and then recheck the last part of the scenario. What is it asking? What is the best next step? Go with the steroid. If it is asking what is the confirmatory test, then go with the A. So read the last part of the scenario 2-3 times before you decide to pick an option. Migraine with aura. A 27-year-old has a recurrent unilateral throbbing headaches lasting 12 hours before the pain shimmering zigzag gradually expands. Gradually expands across the visual field for 20 minutes. She has nausea and prefers a dark room. Neurological examination is done. What is the most likely diagnosis? What is the most likely diagnosis? Migraine with aura, right? Suspect giant cell arthritis, 72, more than 50, old develops, so it should be old woman, develops temporal headache, scalp tenderness, jaw fatigue while chewing. Today she reports transient vision loss. He saw CRPs high. What is the best next step? Should I do biopsy, triptan, oxygen, reassurance? No, steroid. I can do this later. cluster headache needs a rapid route. A 38-year-old has nightly 45 minutes attack of excruciating right retroorbital pain. The right eye tears and the nostril runs during the attack. He paces the room. What is the best? So 38, and it should be male. I have to put a 38-year-old male has nightly when he is resting, right? 45 minutes attack of excruciating pain, retroorbital here, right? So it is cluster headache. What is the treatment for the cluster headache? High flow oxygen. Suspect postpartum cerebral venous thrombosis. A patient 10 days postpartum develops a progressive headache. So it is going to be progressive. Then generalized seizure and left arm weakness. Blood pressure is not severely elevated. Non-contrast CT scan is non-diagnostic. So what is the best imaging for the CVT? MRI, MRV. So even if CT scan is, which most cases, the CT scan is not going to show anything. So we have to do the MRV. The final 1 minute headache algorithm, red flags. If yes, does the patient has red flag? Yes. Stabilize it. Investigate, suspect the secondary cause. The pattern, migraine, tension, cluster are not clearly primary. Acute treatment, much severity, route, comorbidity, and pregnancy status. Prevention needed. Frequent disabling attacks, poor acute response, or overuse. Safety check, medication overuse, vascular contraindication, follow-up, and return precaution. Danger first, pattern second, treatment third. Oh, these are the short notes. I will, this is the, if you know this, basically you can answer any question. If it is about the headache, you would definitely be able to answer any question. I just encourage you guys to take a screenshot of this. And I think I do have it before we start the exam. I can leave it on the screen. And thank you very much. This was the end of the headache. Let's stop it here.